John. We'll hold questions till the end, if that's okay. We're going to move straight on to our next speaker, who in fact is going to be zoomed in or beamed in. It's Yuyun Maryuningsih, and I hope I said that correctly. She's the leader for the blood and other products of human origin based at WHO headquarters. And Yuyun's going to be telling us about blood safety and surveillance. And I think we'll take some questions shortly after that because Yuyun has to beetle off to another meeting, I understand. Yuyun, thank you so much for the time, and over to you.
Good morning, good afternoon, good evening, everyone. I'm Dr. Yuyun Maryuningsih, a team lead for blood and other products of human origin at the World Health Organization Headquarters Office. First of all, I would like to thank the organizing committee for inviting me on this conference on liver disease in Africa 2022 to share the information on blood safety and surveillance. This is the topic that will be included in my presentation: the introduction, importance of ensuring quality and safety of blood transfusion-transmitted infectious agents, blood safety strategy, WHO available guidance related to blood safety, global database on blood safety 2018, and conclusion. We all know that blood transfusion can be a life-saving intervention, but in fact, it can also result in acute or delayed complications and carry the risk of the transmitting infections. That is why the World Health Assembly 63.12 resolution issued in 2010 on availability, safety, and quality of blood products urges member states to take all the necessary steps to ensure quality and safety of blood products. Blood component, and plasma-derived medicinal products has been included in essential medicine list. And as essential medicine, blood products should be available at all times, in sufficient quantity and in appropriate dosage forms of guaranteed quality and affordable. Blood is a national resource and human asset. That is why it is important to ensure the quality and safety of blood, and blood cannot be replaced if transfusion is clinically needed. Unsafe blood is ultimately more costly in both human and economy. So the morbidity and mortality resulting from infected blood has broad consequences for recipients and also for their families, communities, and society. And this situation, furthermore, could increase requirement for medical care, higher levels of dependence, and loss of the productive workforce, which is, at the end, put a heavy burden on health, social services, and national economy. Scientific studies already prove that several infectious agents can be transmitted through transfusion. For example, some viruses like HIV, hepatitis virus, CMV, EBV, etc., and also several parasites such as Plasmodium, Treponemas, and others, and also bacteria can be transmitted through transfusion. TTIA is usually carried by a symptomatic infected blood donor. However, transfusion-transmitted infections are a largely mitigated risk compared to other transfusion risks such as febrile non-hemolytic transfusion reaction, transfusion-related acute lung injury, graft versus host disease, and others. WHO in 2002 has issued the 8th Memoir for National Blood Programs on Blood Safety. This 8th Memoir summarized the blood safety strategy. So the global burden of disease due to unsafe blood transfusion can be eliminated or substantially reduced through an integrated strategy for blood safety, which includes establishment of a nationally coordinated blood transfusion service, collection of blood only from voluntary non-remunerated donations from low-risk populations, testing of all donated blood, including screening for transfusion-transmissible infections, blood grouping, and compatibility testing. Another important strategy is the reduction in unnecessary transfusion through the effective clinical use of blood, including the use of simple alternatives to transfusion such as crystalloid and colloid wherever possible. Another aid memoir issued again in 2002 for National Blood Program on Quality System for Blood Safety described the quality system on blood screening. So the element of this quality system for blood screening should include the organizational management. So for example, the blood center should designate technical officer. And then the blood center also should establish the standard. For example, the protocols for screening, for selection and evaluation of appropriate screening assays to be used. And also all laboratory staff should be trained. And screening of all donated blood for TTIs should implement the good laboratory practice with effective documentation, including establishment of standard operating procedure. Another element of this quality system are procurement, supply, central storage and distributions of reagents and material to ensure continuity in testing at all sites, as well as assessment. For example, joining the external quality assessment scheme on TTIs testing. Furthermore, in the next slide, I will show you the WHO available guidance related to blood safety. So the first guidance is the guidance on assessing donor suitability for blood donation, which was issued in 2009. So in this guidance, we can see the criteria to accept someone to donate the blood, either for regarding or relating to hepatitis B, hepatitis C, and other hepatitis. So, for example, for hepatitis B, we could accept somebody to donate blood if he or she negative for HBs AG and anti-HB core, or if he or she is anti-HB core positive, she should have anti-HBs more than 100 milli-IU per ml. For deferral criteria is someone that has HBV infected or has history of infection within the last 12 months, have sexual or household contact with active HBV infection, then this person will be deferred for 12 months. And healthcare worker with inoculation or mucosal injury will also defer 12 months following exposure. So I guess I will not read all these criteria, but anyway, in this guidance, you can see the exceptions and deferral criteria for related to hepatitis C and other hepatitis. Another guidance from WHO is the guidance on blood donor counseling. So the objective of this guidance is to provide policy guidance on providing blood donor counseling as an essential component of quality donor services and care, and as a requirement for a safe blood supply. Also, this guidance as an information and technical guidance on the specific measures and actions needed to promote donor care and the safety of blood donors and transfusion recipients through counseling, for example, for blood donor with abnormal test results, either for HIV, HBV, HCV, syphilis, or other infectious disease. Furthermore, again, another WHO guidance or recommendation is on screening donated blood for TTIs, which was issued in 2019. And this guidance actually currently under revision. So I will only highlight the hepatitis B related recommendation. So for hepatitis B, the screening for blood donors should be performed using a highly sensitive and specific HBs antigen immunoassay, such as AIA or CLIA, and also this immunoassay should be capable to detect the HBs antigen subtype specific to country or region. A highly sensitive and specific HBs antigen rapid test device, or in the past particle agglutination assay, may only be utilized by laboratory in remote areas or in emergency situations when bank blood is not available. And screening for anti-HB core is not recommended in countries with high level of HBV infection. And furthermore, screening for ALT is not recommended again. Regarding the anti-HB core screening, so we know that anti-HB core is produced later during infection after the appearance of HBsAg. So that is why implementing HB core screening is questionable. And anti-HB core marks the start of immune response to HBV infections. Anti-HB core persists for life, so it can be mean as infection resolves or infection progress to chronicity. However, there are scenarios in which HBs antigen may no longer be detectable. HBV DNA may be present at low level, but anti-HB core is detectable. So this condition known as the person with resolved infections or the person with occult hepatitis B infections. The presence of anti-HB core in the absence of HBs antigen reflect past resolved infections. If anti-HB core screening is being considered to be run routinely, it would be necessary to determine how to distinguish between individuals who are anti-HB core reactive because of previous resolved natural HBV infection and who are non-infectious from those who have unresolved HBV infection and are thus potentially infectious. So in a population with a high prevalence of infection, the number of blood donors with evidence of natural resolved infection is likely to be significant, resulting in the potentially unnecessary discard of donation. Anti-HBs testing for reactive donation would be required to distinguish between potentially infectious and non-infectious. The implementation of nucleic acid amplification for HBV, HCV, and HIV may be considered in countries with high levels of infections if the additional resources needed are available. So furthermore, this WHO recommendation described that highly sensitive and specific combination of anti-HCV and HCV antigen screening assay is recommended to be performed for screening on blood donor. Another recommendation listed in this guidance is that fully automated system proof can offer some benefits. And furthermore, this recommendation stated that new technology such as HBV DNA or HCV RNA blood screening could reduce the risk of HBV and HCV transmission through transfusion of infected blood donated during the window period of antigen and antibody assays. However, as I mentioned before, that any benefit is dependent upon HBV and HCV incidence and the actual number of donations that may be collected in the window period. So in this slide, again, I would like to show you other WHO safety related guidance. There are some guidelines on estimation of residual risk of HIV, HBV, and HCV, in which this guidance actually will help the member state to determine the testing algorithm based on the epidemiology situations in the country. And then another guidance are establishment of external quality assessment program for screening of donated blood for transfusion-transmitted infections, the guidance on protecting the blood supply during infectious disease outbreak, and the recent guidance is on centralizing blood donation testing and processing. So next in our slide, I would like to show you the WHO Global Database on Blood Safety 2018. So this data actually can be used as a basis data for planning a surveillance program. So in the report, there is a table that shows you the number of countries by WHO region reporting less than 100% testing for a major transfusion transmissible infection. So as you can see from this slide, in Africa, around 2 to 5 countries reporting less than 100% testing for HIV, HBV, HCV, and syphilis. And furthermore, in Eastern Mediterranean, 1 country reporting less than 100% testing for syphilis, and in Western Pacific, we can see that there are 1 to 2 countries again reporting less than 100% testing for HIV or HBV, HCV, and syphilis. In this slide, I would like to show you the distribution of blood laboratory screening policies for HBV by WHO region. So as you can see from this slide, in all region, I think not all countries has screening policies towards HBs antigen, and only I think 5 countries, for example in Africa, have a screening policies for HBs antigen plus anti-HB core in routine. And on again in this slide, I think globally, so among 171 countries, only 26 countries have the screening policies to run the HBs antigen and anti-HB core testing routinely. And for selective screening towards HBs antigen and anti-HB core, globally only 4 countries run this policy. And HBs antigen plus nucleic acid tests, globally only 27 countries have this policy. And then furthermore, HBs antigen plus anti-HB core routine plus NAT, only 21 countries, and selectively doing this only in 7 countries. And another table shows you the distribution of blood laboratory screening policies for HCV. So again, globally, only 83 among 171 countries has screening policies on HCV antibody, and only 27 countries have screening policies for HCV antigen and antibody, so combination, and combination between HCV antibody and NAT only in 43 countries, HCV antibody plus antigen plus nucleic acid test only in 11 countries. Again, another table shows you the proportion of blood screening laboratories that participate in external quality assessment for screening of TTIs by World Bank income group. So as you can see from here, not all laboratory join the external quality assessment. So for example, in low income country, only 68% of the laboratories join the external quality assessment for TTIs, while in high income countries, around 88% of laboratories join the external quality assessment scheme. And then the last table shows you the proportion of blood donation with positive or reactive results on screening tests by income group. So you can see from the table that the prevalence of markers of transfusion transmissible infectious disease in blood donation varies inversely by the income status of member states. So for example, we can see that in high-income country, the prevalence of HBV positive blood donation is only 0.02 compared to around 2.8% in low-income countries. So the first table actually showed you that the quality assured testing procedures was not 100% followed. Blood screening towards other TTIAs, as you can see from this slide. So only 14 countries ran the blood screening towards West Nile virus, and only Canada and United States of America ran the blood screening using the RNA testing towards West Nile virus for all donations. And for Zika virus testing, the data showed, the GDBS data showed only United States of America ran this policy. And for human parvo B19 testing, only 4 countries. For hepatitis A virus is Luxembourg and Switzerland, because there is a requirement from the plasma fractionator that all the plasma sent by Switzerland and Luxembourg should be negative for hepatitis A virus. So that is why they run the hepatitis A blood screening. And for hepatitis A, France, Japan, and Luxembourg do the screening on selective donations. While for not testing for hepatitis A virus, again, Switzerland ran this policy for all donations since October 2018. For Brucella infection, there are 3 countries so far informed this policy to GDPS data, which are Argentina, Armenia, and Mexico for all donations. So to close my presentation, I would like to conclude that the TTIs is one risk of transfusion that can be reduced. Careful donor recruitment, selections, and counseling contributes to safe blood. Testing toward TTIs need to be run using more sensitive and specific immunologic assay as well as nucleic acid tests. And quality assurance program need to be run by all blood centers. And numerous WHO guidance are available to assist countries to improve blood safety. So thank you for your attention.